I hope everybody had a good lunch. They give former deputy ministers the tough job of the day, which is I'm only doing introductions, so you should be thankful about that. I hope you enjoyed the lunch. Thrilled today to have Deputy Minister of Health Deborah Richardson here with us. She is a trailblazing leader whose career exemplifies courage, compassion, and commitment to public service. I'm also very proud to call her friend and colleague from our time working together in the Ontario government. Deborah is a proud Mi'kmaq woman from Pabineau First Nation in New Brunswick and is the first Indigenous woman to serve as Deputy Minister within the Ontario Public Service. Over the last 9 years, she has held diverse Deputy Minister positions across the Ontario government, including Deputy Minister of Treasury Board Secretariat, Deputy Solicitor General, Correctional Services, and Deputy Minister of Indigenous Affairs. Those are all complex files which Deborah has led with grace and ease. Deborah is also a breast cancer survivor, and she and her husband Bob are the proud parents of 5 children. Her lived experience brings an important perspective to her leadership. Deborah, on behalf of ICES, I welcome you to the forum and look forward to your remarks.
Kwe, Nindelawisi, Wabano Nungas Kwe, Delewe when Bigajawik. I just introduced myself in my Mi'kmaq language, and my spirit name is Eastern Star Woman. I'm from the Pabineau First Nation, as Helen spoke to, which is the North Shore of New Brunswick, near Bathurst, if anybody's familiar with New Brunswick. My name is Deborah Richardson. So it's really great to be here today, and thanks for the kind introduction. And that's the beauty of sitting beside Helen before. I'm like, yeah, scratch it out, scratch it out, scratch it out. I don't know how these bios end up coming before people, but it's actually quite entertaining. So I've been the Deputy Minister of Health for oh my goodness, about 1.5 years now. And it was funny initially when, so for deputy ministers' portfolios, and I think it's almost 11 years now I've been a deputy minister, but it's fascinating. You're just kind of told where to go. So you're either told to leave or you're told to go to a different portfolio. And when Michelle D'Emmanuel, who is the Secretary of Cabinet, said, Deborah, you're going to health, and I'm like, oh my gosh, like I'm not a doctor, I'm not a nurse, I feel like a bit of an imposter. And she's like, no, Deborah, like you're a cancer survivor, you're a patient. And I was like, yeah, I am a patient. So here I am. So really thanks for organizing this gathering, and to all of you in the room. It's just amazing. Researchers and clinicians and policymakers, healthcare administrators, community partners, and many others. Thanks for all that you do. And the truth is, a lot of what you do and a lot of even what I do is behind the scenes. And it doesn't always make the headlines, but it does shape policy. And it drives change, and it saves lives. So whether you're crunching data, coordinating studies, delivering care, or listening to patients in the quiet moments, it all matters. All of it does. In this forum, this community is a reminder that when data and compassion come together, incredible things are possible. When I look around this room, I just don't see people, professionals, people working in the space. I see people carrying responsibility for systems, for communities, for outcomes that will shape lives long after this forum ends. And this gathering isn't just about research, it's about connection. It's about our shared collective responsibility to build something stronger, smarter, and more human. It's not always about AI. Today is an opportunity to reflect. It's a time to listen more deeply, to ask better questions, and to reimagine how innovation can serve equity, not just efficiency. That's the human part. Like many jurisdictions across Canada and others around the world, Ontario's healthcare system is under real pressure. It's funny going from Treasury Board to going to health. So when I was at Treasury Board, I'm like, that health. What's wrong with that Ministry of Health? Now I'm in those shoes where I'm at health, going to Treasury Board and saying, what's wrong with you people at Treasury Board? Health needs money. It's poetic justice is a phrase. So we're seeing a rise in demand for services, and you all know this from the data. But it's important to always level set ourselves and remind ourselves we've got a growing elderly population, increasing complexity in care needs, persistent gaps in access and outcomes, and ongoing economic certainty. It's pretty scary. You just have to open the newspaper and you see all the industry that's collapsing here in Ontario, but right across Canada and actually around the world. So the cost of care continues to grow, even as expectations placed on our system and on you, all of us, remain high. The old models are being stretched well beyond their limits, and that's why today's theme is so relevant. I loved it. Planning for the future, advancing health through innovation. We have to do it. We absolutely have to do it. It's not something that we turn to when everything else has failed. It's how we grow. It's how we evolve. It's how we respond. It's how we rise. For over 3 decades, the Ministry of Health has partnered with ICES to build a smarter, more connected, and more equitable healthcare system. This partnership is not just historical, it's foundational to today's healthcare system. From its founding in 1992 with the Ontario Medical Association, ICES has grown into a world-class institution. It stewards over 120 health-related data holdings representing many, many millions of Ontarians. It runs one of the most advanced privacy-protective computing environments in Canada. ICES doesn't just hold data, it protects it, it connects it, it transforms it into insight. Its computing environment is among the most advanced in Canada, enabling secure, privacy-protective research that serves all of us, all of Ontarians. But numbers only tell a part of the story. ICES has become a space of trust, a place where science, policy, and community come together, where questions are asked not just for knowledge, but for impact. From chronic disease to mental health, from primary care to Indigenous-led research, ICES continues to ask the questions that matter and deliver answers that drive change. This forum is more than just a conference, it's an incubator. It brings together the minds and hearts that shape Ontario's health future. And that culture of impact doesn't just happen by accident. It's shaped by leadership. And I want to take a moment to recognize Dr. Michael Schull, who will be stepping down as CEO. And Michael, under your guidance, ICES has deepened its national and global reputation, expanded its partnerships, and remained steadfast in its commitment to public service and data stewardship. It's amazing. Actually, let's give a round of applause. You have led with humility, with clarity, and with vision. And on behalf of all of us and all of Ontarians and all of Canadians, thank you. Willaliyuk. And we know that when Dr. Astrid Gutman becomes interim CEO next month, we can look forward to the same high standard of leadership for ICES. And I'm looking forward to seeing Astrid's continue focused on improving children's health outcomes and her health policy and public health advocacy. ICES is in good hands. It feels good, doesn't it, when you step aside and you leave an organization in good hands. That shows good leadership as well. And that matters because the challenges ahead demand bold, evidence-informed action. And we're at a moment where innovation is no longer a luxury. It must be intentional, inclusive, and measurable. Earlier today, Minister Jones, who I adore, by the way, spoke about Ontario's Your Health Plan. Ontario has invested in strategies that build for the future, including over $201 million through the Life Sciences Strategy to help make Ontario a global hub for biomanufacturing and innovation, and the Health Innovation Pathway to bring promising technologies into real-world healthcare settings more quickly. Through a multi-year investment, the ministry continues to support ICES's vital work, and we're continuing to make bold investments because partnerships help us foster an equitable and accountable healthcare system now and into the future. Organizations like ICES make sure new tools are evaluated thoroughly, implemented ethically, and applied equitably. ICES ensures we ask the right questions before we scale, and that our success is measured not only in efficiency, but in impact. And this really matters. When we're going to Treasury Board and we're presenting business cases for investments or other things, having that evidence just makes the world a difference. And I should point out ADM Michael Hilmer here, who is a total rock for me at the ministry in terms of data. And I know many of you have a fantastic relationship with him. We're very blessed to have him. So this morning's panel, and I'm sorry I wasn't here, but I'm told, explored the potential and limitations of artificial intelligence. We all know the promise. AI can predict disease, personalize treatments, and improve workflows. But it also carries risk. If not built carefully, it can reflect the same biases, blind spots, and systemic gaps, the very ones that we're trying to fix. That's why ICES's work in advanced analytics, grounded in equity and ethics, is absolutely essential. The use of AI, like any tool, must be guided by principle, by people, and by community. A meaningful example of principle-guided innovation is ICES's commitment to Indigenous data sovereignty. In 2024, ICES formalized a new department, Indigenous Partnerships, Data and Analytics. This wasn't just an organizational change, it was an act of respect, a commitment to self-determination. It recognizes the inherent rights of First Nations, Inuit, and Métis communities to govern their own data, set their own research priorities, and define what success looks like for their people. For my people. This is not about consultation, it's about collaboration. It's about standing beside, or sometimes standing from behind, and not above, not ahead. It's nothing about us without us. It's funny, my dad's on band council of my First Nation in New Brunswick, and my husband one time did a TED talk saying that if you want to develop relationships with Indigenous people, you need 3 cups of tea. My dad says you need 50 cups of tea. So anyway, so start drinking the tea if you're going to establish relationships with communities. And I think it's with anybody, right? You can't just meet with them and get down to business. You want to actually establish a relationship and a connection, and then you get down to business. And then it helps with the good times and the bad times. During my own cancer treatment, I had the support of Indigenous patient navigators in the system. I was able to access a space at Sunnybrook Hospital where I could smudge and have ceremony and access a sacred fire. I was able to do, obviously, my own ceremony and worry about my spirit. I was supported by organizations like Anishinaabe Health Toronto that allowed me to heal, not just my body, but my spirit. And that's what a culturally safe care looks like. And it's different for every single one of us. I wanted traditional medicine, and I wanted Western medicine. I wanted everything to make sure that this cancer didn't come back. And that's what data sovereignty can help make possible. Because at its heart, this work is about trust. And I want to share a set of teachings that many of you might have heard before. They're in schools and they're in different places, but they always guide me in every aspect of my life, and that's the 7 grandfather teachings. They are wisdom, love, respect, bravery, honesty, humility, and truth. And in my culture, they're more than just values. They're instructions for living in balance with ourselves, with each other, with the land, and with the future that we're shaping. Everyone is connected. For example, you cannot have truth without humility. You cannot show love without respect. And real leadership is rooted in all 7. And these teachings remind us that the work we do today is not just about the now, it's about what we leave behind. There's a teaching around, people hear about 7 generations, and it's not like today it's 7 generations that are ahead of me. I'm in the middle. It's the generations, what have people and all of the great people who've worked in data and all that space have done before? What am I doing today? And then what am I doing for the next 3 generations beyond me? And it reminds us that leadership isn't about titles or about authorities. It's about service. Whether you're in a clinic, in a lab, in a classroom, or a boardroom, if you're leading with care and with purpose, you're already walking in those teachings. When I look around this room, I see those teachings in action. Whether or not you name them in the same way, you carry them in how you care, how you question, how you lead. Earlier this year, ICES collaborated with the Canadian Partnership Against Cancer, the Canadian Cancer Society, PHAC, and Statistics Canada to analyze the economic burden of cancer. Using the OncoSim model, the study found that cancer costs nearly $33,000 per patient. Once you count for treatment, lost income, personal expenses, hospital parking. It also shows that these costs hit low-income, rural, and marginalized Ontarians the hardest. And it really registered with me because when I went to Sunnybrook, and I live in Markham. I have a house in Nipissing First Nation near North Bay, but I live in Markham. You know, I'm able to just drive to Sunnybrook. I have a car. Imagine if you don't. I couldn't imagine having to take the bus after chemotherapy, worrying about the expenses of what those are. I was fortunate that I have sick leave at my work. Some people don't have sick leave. Those are hours that they're not working. So, you know, it really, you recognize what a state of privilege that many of us have versus many that do not. So it's always a reminder of thinking about that. And it's not a statistic, it's a story. And it's a reminder that data, well held with care and purpose, can shine a light on injustice and help us do better. And as I look ahead, I offer an invitation. Go deeper. Mentor generously. Question boldly. Listen with humility and with your heart. Let your work be guided not just what's measurable, but by what's meaningful. Because the future of Ontario's healthcare system is not something that we inherit, it's something that we build together. And we must build it with care, with courage, and with truth. And so to everyone, again, I thanked you at the beginning. Thank you so much for all that you do and your commitment to making this world a better place. Whether you're working in Indigenous health, in rural care or equity-focused spaces, know that your voice is not just important, it's needed, it's essential. And the Ministry of Health and ICES are here to support you and to learn from you. And let's keep building a system that's resilient, responsive, and rooted in truth. So thank you, Miigwech. Merci beaucoup. Wilaliuk.
Wow, that is a tough act to follow. Thank you so much, Deputy Richardson, for those words, those reflections. I definitely understand why Michelle Dumanuel asked you to be the Deputy of Health. Your passion really shone through there in your words for the mission of the ministry, but also your words about the work of ICES and the work that we do collectively with our partners, including Indigenous partners. I think really is so important to all of us. I think everyone in this room really appreciates the understanding that you demonstrated for the importance of the work that we do and our efforts to support the ministry in its work. I think there's so much more that we can be doing together in the future, and I know that Astrid will be leading that charge very shortly. And I'll just point out, in terms of 7 generations, Astrid will be the 7th CEO, so there's something happened there. Okay, so now we're going to transition to the rapid fire sessions. These are always a big hit at all of our research fora, and it'd be great to see the competitive juices flowing here at ICS. So I'm going to hand the mic over to Mike Patterson. Mike is a senior scientist and program lead for the chronic disease and pharmacotherapy research program at ICS. Mike has also been a science advisor. He stepped in as chief science officer when Astrid was on sabbatical for a year. And Mike holds the title as the longest-serving employee of ICES. So let's hear it for Mike.
So nice to see so many familiar faces in the audience. Great to be able to be together again in person. So first off, I'm delighted to be able to moderate today's exciting rapid fire session. And while I describe what we're about to see, I'm going to ask all of the presenters to come up and join me here. Invite them up. You've got seats assigned here for you, and I'll just pause while you join me here on the stage. So for those of you who have not seen a rapid fire presentation, they're effectively an elevator pitch of sorts. We're giving each of our presenters 3 minutes to deliver the key messages that flow from their work. And keeping with the theme of planning for the future, today's session will include 9 presentations of student and postdoctoral fellow projects. And those students and postdoctoral fellows will be joined by an additional presentation of one of our applied health research questions that came to us from a community partner. Each of the trainee presentations was nominated by the program lead of each of our 8 research programs. So we have a good breadth of presentations today, and we're really looking forward to what's to come. Unfortunately, given the number of presentations, we won't be setting aside time for questions, but please feel free to, at the break, approach our speakers or send us an email, and we'll get back to you on any questions that you have. Finally, as Michael indicated, at the close of our session, we will have an opportunity for the audience to participate and vote on the best pitch among the 9 presentations. So I'll call up our first presenter. The first is our Applied Health Research question project, and so Leslie, if you'll come forward. Leslie will be talking about the health and well-being of the Somali population in the Greater Toronto Area. Leslie?
Thank you, Mike. Hi, everyone. I'll just get right into it. So increasing access to data for community organizations has been a key priority at ICES. Through ministry-funded Applied Health Research Question, or ARC program, we've been able to help groups use data to better understand and serve their communities. Through this program, ICES conducted a project with the Black Muslim Initiative, or BMI, a Toronto-based nonprofit addressing issues at the intersection of the Black and Muslim experience, to examine the health and well-being of the Somali population in the Greater Toronto Area. Using administrative data, we identified over 23,000 Somali-born or Canadian-born children of Somali mothers and described their sociodemographic characteristics, their healthcare use, and comorbidities by GTA region and generational status. One key finding showed cancer screening rates among screen-eligible Somalis that were lower than the rates in the general GTA population, with notable regional differences as shown in the graph. These insights highlighted areas where community-driven initiatives could strengthen wellness and preventative care, including opportunities to enhance cancer screening participation and early detection efforts across the regions. Complementing this, BMI actually conducted a community health survey among 227 Somali GTA residents. The survey invited participants to share their perspectives on key health priorities and experiences in the healthcare system. 9 priority areas emerged, including cancer and preventative screening, and key barriers to navigating the healthcare system were identified. And these included limited healthcare provider access and appointments, financial constraints and time pressures, language barriers, lack of trust in the system, and experiences of racism. Together, the data provided by ICES and the community insights from the survey created the basis for BMI's comprehensive report on the health and well-being of the Somali population and shaped a set of recommendations to advance Somali health. These included improving service awareness and navigation, expanding culturally responsive healthcare services, strengthening access to primary care with the hopes of improving cancer screening rates, and developing a Somali health hub that integrates clinical, social, and community services. Overall, this collaboration between ICES and BMI through the ARC program shows how community organizations can meaningfully use data to drive change and empower the community. It has fostered partnerships among community leaders, clinicians, and decision makers to design interventions that enhance service delivery and improve health outcomes for the Somali population in the GTA. Thank you.
So next up is Joshua Sarasulo, and Josh is going to present some material from his PhD thesis, Outpatient Follow-Up During Survivorship, a population-based study of prostate cancer survivors after first-line radiation. Josh?
Thanks, Mike. So by the year 2050, it's estimated there's approximately going to be 1 million Canadian men living with prostate cancer. That's roughly the size of the city of Ottawa. Right now, prostate cancer costs the Canadian healthcare system around $2 billion per year, so that's roughly enough to hire about 20,000 full-time nurses. Prostate cancer does, however, have one of the best survival rates among any cancer site, which shifts the economic burden from acute treatment to long-term survivorship care. So typically, a prostate cancer survivor will see their specialist around 1 to 2 times per year in the long term. So if everybody in 2050 was to exhibit that same healthcare utilization, that's approximately 1 to 2 million healthcare visits just simply on follow-up. So that has huge implications for an already overtaxed cancer care system. So what we set out to do was look at the patterns of outpatient care, particularly with radiation oncology, among prostate cancer survivors in their survivorship phase of care. So we started year 3 following the completion of the radiation. And the good news, so on the left-hand side of the slide, what we found was that as one's risk increased, so did their intensity of follow-up with radiation oncology. Lower risk, lower intensity. So that's great to see. However, when we looked at how long this follow-up persisted and the timing of the follow-up, that was somewhat concerning. So on the right-hand side, you see the proportion of patients, prostate cancer survivors, that are still seeking radiation oncology follow-up within a cancer care center. The good news is that's decreasing over time to about 25% in year 5. So 1/4 of survivors are still seeking active radiation oncology follow-up 8 years following the completion of their treatment. That's a lot. Half of these people in year 5 are among the 2 lowest risk strata. So the lowest risk individuals are essentially still seeking specialized follow-up within a cancer hospital. So what we plan to do is better identify who among them can transition from radiation oncology follow-up to active surveillance with their primary care physician within their home community. And what this will do is will free up the cancer care system for high-risk, newly diagnosed cases and allow long-term survivors to shift their long-term surveillance to their primary care physician, somebody who they're familiar with and in their home community. And one more thing, go Jays go. Thank you.
Thank you, Josh. Next, from the Cardiovascular Research Program, Mohammed Sharab, and Mohammed's going to speak about Bridging the Gap, Regional and Rural Urban Disparities in Atrial Fibrillation Care and Outcomes. Mohammed?
Thank you so much. Good afternoon, everyone. So I just want to disclose I'm a clinician who practices in Northern Ontario, and wanted to highlight and share some of the work that we have been conducting recently, looking at regional and rural disparities in the care and outcomes of patients with atrial fibrillation. Atrial fibrillation is a very common cardiac disease. Around 40% of patients with cardiac problems suffer from atrial fibrillation, and very little is known about regional and rural variations in outcomes and care. So those are 2 different analyses. To your left, you will see that we looked at the outcomes of AF patients presenting to the emergency department in different regions within Ontario. So we have divided this into the 5 major regions based on Ontario Health, so North, Toronto, Central, West, and East. The color coding is related to the risk of all-cause death or hospital admission. The darker the color, the worse the outcomes. And as you can see to the left, the map shows higher rate of all-cause death or hospitalization among patients with atrial fibrillation who live in Northern Ontario. Now, those patients also suffer higher rate of ED visit, less primary care physician and cardiology follow-up. So we took this project a step further. To your right, you will see a different analysis that focused, though, on rural and urban disparities in the care of patients with atrial fibrillation. So we looked at all communities that have that defined rurality based on a population size of less than 10,000, based on Statistics Canada. And again, we've seen the same disparities where patients with atrial fibrillation living in rural areas and rural communities have higher rate of all-cause death or admission and ED visit. Not only that, but there are much more data looked at processes of care. So they have less cardiology follow-ups. They use more medications that are not contemporary, such as warfarin, to prevent stroke from happening. So my conclusions are not to discourage you to move to Northern Ontario, but certainly for all of us as clinicians and policymakers to try to develop system-level interventions to bridge the gap between different regions and rural and urban communities. Thank you.
Thank you, Mohammed. Next, from my own Chronic Disease and Pharmacotherapy Research Program, Ghazal Fazli will present some material from one of her postdoctoral projects, the title, Impact of the COVID-19 Pandemic on Type 2 Diabetes Screening and Incidence. Ghazal?
Hi, everyone. So in order to set the stage for this work, I do have to take you back a little bit in time, which you may not like, and that's the global pandemic, the COVID-19 pandemic that we encountered. At the onset of the pandemic, there were many hypotheses about how the pandemic is going to change our trajectory in health, and that includes chronic disease, which is what we were focused on with my postdoc supervisor, Dr. Gillian Booth, at the time. We were interested in understanding given the shifts in our lifestyles and health behaviors, we were working from home, we were sedentary for the most part, and snack consumptions, and we weren't as physically active. So how did the pandemic impact access to healthcare and type 2 diabetes incidence? To do this work, we conducted an interrupted time series analysis. Usually policy researchers use this methodology because they want to evaluate the change in, after a policy has been implemented, to look at the change in the slope over time. Many studies came out of during the COVID-19 pandemic where many researchers were interested in the pre and post-pandemic across mental health and chronic disease and various different disciplines. So we conducted a time series analysis using this methodology among adults living in Ontario aged 20 and above who underwent screening and were free of type 2 diabetes. We accessed the administrative databases at ICES, and so just to give you ballparks of numbers, among 20 plus adults, we have access to about 10 million individuals, and on average, we have about 500,000 individuals who undergo screening on a monthly basis. So very robust, very rich data that allowed us to do this work. Not to mention the Ontario Diabetes Database that also allows us to estimate future diabetes incidence. So we wanted to estimate the expected and the observed number of people over time over the course of the pandemic, but prior to the pandemic and during the pandemic. We, as you can see, to get to this graph, we fitted a negative binomial regression model using time period and month as predictors, and that was used to predict the monthly expected diabetes screening rates for diabetes and incidence after March 2020. And we compared the observed and the expected rates before the pandemic and during. So what I'd like to jump on as to conclusions here is that in April 2020, diabetes screening dropped by 70% in Ontario, and diabetes incidence dropped by 45%. During the pandemic, there was some recovery during certain months, but over time, in March 2023, we saw screening went up to levels prior to the pandemic. However, incidence really exploded in the province, which was something that we had anticipated and hypothesized. In summary, this has significant implications for delayed diagnoses, missed opportunities, and really positions us in a way to understand what is the current context with the diabetes epidemic and what do we need to do to respond to this. Thank you.
Thank you, Gazelle. Next up, from the Kidney Dialysis and Transplantation Research Program, a graduate project, Kyla Naylor will be presenting Defining Preemptive Living Kidney Donor Transplantation as a Quality Indicator.
Imagine a patient sitting in a kidney clinic. Their kidney function is declining rapidly, yet this patient has not yet started dialysis. For this patient, a preemptive kidney transplant is their best treatment option. A preemptive transplant is a transplant that occurs before the patient starts dialysis. Why is this better treatment option? Well, it results in improved graft survival, better quality of life, and lower cost to the healthcare system. Yet, less than 10% of all transplants in Ontario occur preemptively, and until now, there has been no clear way to define and measure preemptive kidney transplant. So what our team sought to do was to define preemptive kidney transplant as a quality indicator, specifically preemptive living kidney donor transplant. Why living kidney donor transplant? Well, about 98% of all transplants that are preemptive occur from a living donor instead of a deceased donor. So we used administrative databases at ICES to understand how to define a population at risk for preemptive kidney transplant. So we built 4 different cohorts of adults with advanced chronic kidney disease. Our first cohort was our most inclusive cohort. It included everyone with advanced chronic kidney disease. Down to our 4th cohort was our smallest, or most restrictive cohort, restricted to patients who are at highest risk of developing kidney failure and had no recorded contraindications to transplant. We then sought to determine how the rate of preemptive transplant varied across those 4 cohorts. And here's what we found. Depending on how you define the denominator or our 4 cohorts, the incidence of preemptive kidney transplant changed substantially, over twofold in fact, from 1 to 2 rate of preemptive kidney transplants per 100 person years. And this difference was caused entirely by how we defined our population. So what is our takeaway? Before we can benchmark programs in the province on how they're doing with regards to improving access to kidney transplant, we need to agree on how to measure success. By testing multiple different definitions, we show how provinces and eventually the nation can use administrative data to track, develop, and identify gaps in the system. This approach can be also extended to other indicators, such as kidney transplant referral, which we are currently doing. In short, how we define things matters. A clear, consistent definition of preemptive living donor transplant is our first step towards measuring and improving access to kidney transplant in our province. The next steps for this work include continuing to work with our knowledge users, which are the Ontario Renal Network and Trillium Gift of Life Network, to further refine this quality indicators with the eventual goal that they can distribute this metric to the transplant centers across Ontario so they can monitor, track, and improve their performance. This work is currently published in the American Journal of Transplantation for anyone who would like to read about our work further. Thank you.
Thanks very much, Kyla. Next, from the Life Stage Research Program, graduate student project, Bailey Milne, and she'll be presenting the effect of infertility on congenital anomalies, a population-based cohort study. Bailey?
Fertility treatment has been associated with an increased risk of some congenital anomalies. This has been well established. However, most of these studies compare birth outcomes in those conceived by fertility treatment to those conceived without assistance. These estimates reflect both the impact of the fertility treatment and the underlying fertility. So, Our main question was, what is the impact of the underlying infertility on risk of congenital anomalies? So infertility is defined as the inability to conceive for those trying for more than 12 months. However, many of these people are able to conceive without assistance, and that's defined as subfertility. Using ICES data from 2006 to 2021, we had a cohort of 1.5 million eligible births, and we looked at congenital anomalies classified by organ system and specific anomalies. However, this is not shown on this slide. We found that there is a significantly increased risk of all organ systems with the exception of respiratory anomalies. Anything to the right of that big red line shows a significantly increased risk. We also mapped out the risk based on mode of conception. So OI is ovulation induction and IUI is intrauterine insemination, then IVF or intracytoplasmic sperm injection. So you can see with the more invasive treatment, there is greater increased risk for most anomalies. When we use subfertility as the reference group, those conceived by fertility treatments had no longer significant associations for many of these risks of congenital anomalies. So these findings show that while infertility treatments increase the risk of these anomalies, the underlying infertility is also an independent risk factor of most organ system anomalies.
Thank you, Bailey. Next up, from the Mental Health and Addictions Research Program, a graduate student project from Catherine St. Cyr. Catherine will be talking about mental health service use among Canadian veterans in Ontario, a retrospective cohort study. Catherine.
Thank you. So members of the Canadian Armed Forces, or the CAF, and the Royal Canadian Mounted Police, RCMP, experience a number of unique occupational stressors, and these can include things like deployments away from home, repeated exposure to psychologically distressing events, and an increased risk of workplace injuries that could result in severe harm or even fatality. So importantly, the experiences of female CAF and RCMP members can be very different from those of their male counterparts. For example, it wasn't until 2001 that female CAF members had equal opportunities to serve in all CAF occupations, and an estimated 9 out of 10 military sexual assaults occur amongst females. All of these occupational stressors can lead to the development of mental health concerns that sometimes result in the end of a military or policing career, and sometimes members delay seeking treatment for mental health concerns until they leave the forces. So females represent about 15% of CAF members and veterans, and they've historically been underrepresented in health services research. So using population-level data from ICES, we aim to explore how veteran status and sex influence mental health care service use among CAF and RCMP veterans residing in Ontario between 1991 and 2023 using a matched retrospective cohort study. We looked at 3 different types of mental health outcomes. So we had mental health outpatient visits with a primary care provider or psychiatrist, mental health-related emergency department visits, and mental health-related hospitalizations. And so on the bar graph in front of you, we see that almost 45% of female veterans had at least one mental health-related outpatient visit in the first 5 years post-service, compared to about 40% of female non-veterans during that same time period, and about 31% of male veterans. Now, for both emergency department visits and hospitalizations, it's much smaller numbers overall, but a larger percentage of female veterans, followed by male veterans, had at least one of these types of mental health encounters compared to non-veterans. We then used extensions of time to event modeling to explore the adjusted hazard ratios of these mental health encounters, and found that across all 3 types of mental health services, the effective veteran status was stronger amongst females. So the main takeaways from this research are methodological, that veteran health researchers should conduct sex-stratified analyses whenever possible so that the experiences of females are not masked in overall estimates. And then clinical as well, so that female veterans appear to be at increased risk of experiencing mental health concerns, including severe mental health concerns, and that more research is needed to better understand their unique mental health needs. Thank you.
Thank you, Kate. Next up, from the Populations and Public Health Research Program, Zoe Greenwald will present Advancing Public Health Research Methods for Hepatitis C Among People Who Inject Drugs in Ontario. Zoe?
Thank you. Ontario is committed to ending hepatitis C as a public health threat by 2030. That's just 5 years away, and we have effective cures with rates of over 95% success that have been funded in Ontario since 2015. But modeling shows that we're not going to reach elimination by 2030, and we're estimated to get there only by 2040, which is far behind neighboring provinces. Where's the gap? We're missing populations who matter most. People who inject drugs are estimated to account for nearly half of hepatitis C prevalent cases in Canada and 85% of incident infections. And historically, these populations have been very hard to capture in administrative data. So that's where my thesis project came in. Our first objective was to validate algorithms to identify injection drug use, and the second objective to apply these within a population-based cohort. Our validated algorithm included physician billing codes, hospitalizations, and ED visits for drug use, opioid agonist treatment dispensations, and injection-related infections. We validated several algorithms. The ones applied in my thesis work included an algorithm for history of injection drug use that had a sensitivity of 92% and a specificity of 94%. We also validated algorithms for recent injecting that had a sensitivity of 80%. When we applied these to the data, here's what we saw. We captured 5 million Ontarians with hepatitis C testing records up to 2022, and of these, 109,000 had indication of a hep C positive record. When the algorithms were applied, nearly half of the cohort had an indication of injecting, with 27% of the cohort having recent injection drug use within the past 3 years. And looking at how this impacts treatment uptake and equity, we've seen big improvements over time. So in 2015, there was an estimated 31% treatment uptake rate among people with a history of injecting versus 43% among populations without any indication of injection drug use. And by 2022, the treatment uptake rate had more than doubled among people who inject drugs, and we had a treatment uptake of 69%, which was very close to the uptake rates among populations without an indication of drug use of 73%. So here's what this means. We have validated tools that are able to capture injection drug use in population data. We've made these tools available for ICES researchers via concept dictionary entry, thanks to the Pop Health team and DQIM. We've also cleaned a lot of OLIS data that has been used to train the ML models that were talked about earlier today. Using this data, we can understand where we're going in the hep C epidemic and track populations over time to improve population health. Thank you.
Thanks very much, Zoe. And last but not least, from the Primary Care and Health Systems Research Program, Camilla Premji will talk about trends colliding, aging comprehensive family physicians, and the growing complexity of their patients. Camilla?
Thank you, Michael. The working age population has never been older. This is a direct quote from Statistics Canada. In fact, the population of older Canadians is growing 6 times faster than that of younger Canadians. Canada's aging population has implications on both the supply and demand side of primary care. Our team sought to understand both sides of that equation by asking, as our population ages, do we have adequate capacity in the family physician workforce to absorb the patients whose family physician retires? To answer this, we need to know who's near retirement, who are their patients, and what are their primary care needs? What are the trends in the family physician workforce? Who are the physicians who will be absorbing these patients, and will we have enough? Using ICES datasets, we identified Ontarians who have a comprehensive family physician and explored the characteristics of these patients and their doctors over time. By comprehensive, I mean that longitudinal, cradle-to-grave primary care most people think about when they think about what it means to have a family doctor. We looked at patients and physicians at 4 time points between 2008 and 2022, and we honed in on 3 near-retirement physician age groups, those aged 55 plus, 65 plus, and 70 plus. We found that older doctors are making up an increasing proportion of the workforce. As of 2022, almost 40% of family doctors are age 55 plus. And this translates into huge numbers of patients attached to a near-retirement family physician. As of 2022, 1.74 million patients have a family doctor age 65 plus, and of those, 722,000 have a doctor age 70 plus. Patient complexity has increased. The mean patient age is higher, and an increasing proportion of practices across all physician age groups are made up of patients with the highest complexity. When comparing patients served by the overall workforce versus the near-retirement workforce, a higher proportion of patients who are elderly or who have chronic conditions are attached to a near-retirement family doctor. We also see other concerning workforce trends. The family doctor workforce grew between 2008 and 2019, but then stagnated between 2019 and 2022. As well, in 2022, for the first time in our study period, the number and proportion of younger family doctors declined. We also saw a continuing trend away from comprehensive primary care. As of 2022, only 65% of family physicians are practicing comprehensive care, compared to 77% in 2008. Finally, when looking at other trends in our data, like physician sex, roster sizes, as well as other data around the choice of family medicine as a specialty by trainees, there's likely limited capacity in the workforce to absorb impending retirements. And this is all happening in the context where over 2 million Ontarians are already without a regular source of primary care. In summary, the family physician workforce is aging alongside its patients, and this has important implications for workforce planning. Thank you.
Thank you very much, Camilla. Well, first of all, I just want to congratulate all of our presenters. It is not an easy task to distill these enormous projects down into a 3-minute pitch, and so I just would like to give them all a round of applause for the great work. So now, with the help of a team, if you could pull out any mobile devices that you might have, I'll turn to the team for our rapid fire vote from the audience. So if you could just use the QR code there to bring up the survey. Give folks a few minutes.
Mike, can we vote for ourselves?
Yeah, you can vote for yourselves, yes, of course. Let's just let things stabilize a bit here. Oh. Still a few voters coming in. It's a horse race. Whoa. People are... So, when should we close the survey? If we wait another minute, maybe another vote will come in. Folks all place their vote? No? This could go on all day. We do have another session coming. Okay, we're going to give until 1:55, and then that will be the official count. Looks like it's stabilized. 30 seconds. Any last votes? Ten seconds. Any final votes? Oh my goodness. Okay, that's it. The votes are in. We have a tie. Josh. Congratulations to Camilla and Josh. Very well done. And I think, Michael, are you going to announce the next session? I guess we have a break until 2:20. But thank you again, all of you, for your presentations and joining today. And thank you for your participation.
That was great, guys. Thank you all. All right, that was an awesome session. Congrats to all the presenters, winners, and runners-up. So we're going to take a short break. It's actually an ice cream break. There's actually ice cream. So get your ice cream bar and some coffee. And following the break, we're going to invite you to join the breakouts. See how you say ice cream and pandemonium breaks out. I've lost control. Go to the breakout session of your choice after you grab ice cream.